Good morning and welcome to Alcohol Action Ireland's first event of End the Silence Week. I know we're going to have quite a few people who are joining us now, so I'll just let the participants come in and we'll get going in about a minute's time. It's great to see actually all those familiar names kind of flooding in, so thank you indeed to everybody who's has been contributing to this series of events. And as I say, we'll get going in about a minute. And again, thanks to all our participants. Okay, so I'm going to just start and just to remind everybody that I am actually recording. We are recording this event and it will go up on our website afterwards. So our event today, Traumas Ripples Through Time. What we hope to do this morning is to explore some of the issues around problem alcohol use in the home. My name is Sheila Gilheany. I'm CEO of Alcohol Action Ireland, and I'm joined here by a very distinguished panel of speakers. What we hope to try and get across today is that we know that there are impacts on growing up with alcohol harm in the home. There's about 200,000 children right now living in this situation, and there's another 1 million adults who have grown up with that trauma and can be carrying the legacy of it for a long time. But it's something that can be addressed, it can be challenged, it can be helped in various ways. And over the course of this week, we are running a series of different events, trying to look at these different pathways perhaps to healing and looking at some of the evidence behind some of the policy actions that could help us. So this morning, we, in a little way, I suppose I would say we're kind of starting at the end. We're probably looking more to where is the impact and how has it been experienced by adults. And to get us started on that, I'm going to be handing over shortly to Professor Clíona in Cheallaigh. Clíona is Associate Professor in the Department of Clinical Medicine at TCD, and she's also a consultant in James's Hospital. She's the clinical lead there for the Inclusion Health Service, and her research work would examine the effects of social exclusion on health, including the work on health systems design and evaluation, things like premature aging and homeless adults, and the effects of social exclusion on the immune system. You might be kind of wondering, well, how does all of that relate, to our topic today on adverse childhood experiences and the trauma that comes from that? Well, what Clíona is going to be talking about is using transformational stimulation for trauma-informed care in hospital. We know that alcohol certainly has an impact on people's health, but it has a specific impact on children and the adults and on their health, be that mental health or physical health. And all of that can really impact any of them when we would actually find ourselves in hospital. So Clíona, if it's okay with you, and I hope you're ready to go, I really appreciate you joining us here because I know you have a tricky situation this morning. So there we are. I see your slides, so I'm going to hand over to you at this point. Thanks very much.
So thanks so much, Sheila, and thanks to everybody for being so understanding about me changing the timing of the talk and doing it from a car. So we are on our way to a funeral in which alcohol played no small part in leading to the very premature death of the lady that passed away. So it is a good opportunity to highlight that. You can see my slides, I presume, Sheila, can you? Great. Okay. So thank you for the kind introduction. So I'm a consultant in inclusion health, which is a relatively new specialty developed in Ireland, where what we do is provide dedicated hospital care, inpatient and outpatient care, as do other hospital specialties, for people who've experienced a lot of psychological trauma, have a lot of addiction, and who find hospital settings very difficult to navigate. And the reason it's called inclusion health is because the onus is on us as a healthcare system and people who work in it to be inclusive and make sure, if patients don't find our services accessible, the onus is on us, responsibility is on us to make that happen. And also, in order to meet the needs of the people that we work with, we need to be very inclusive of not just thinking about what tablets they need or what surgery they might need, but what are their psychological needs, what are their housing needs, and all of those other elements. So I'll just talk a little bit about that today. I wanted to start with a case. So this is a lady I saw last week in the A&E department. And actually, I lost my cool and went into a trauma response when I saw her, for many reasons. But she would be fairly typical of the patients that we work with. So very, very severe experiences of very high levels of childhood trauma, addiction to alcohol and drugs from a relatively young age in adolescence, and then has been homeless for most of her adulthood. And she was very distressed and dysregulated when she was in the emergency department. She was cursing, she was looking for her stuff, which she didn't know where it was. And she had been barred for, she was getting barred for being aggressive, which was the point where I lost my cool and shouted at the nurse in charge on the morning, you know, this lady has had a lot of trauma in her life, and we need to consider that in how we look after her. And she was just a really good example for me of that high level of need for health services, but the inability of the health services really to meet her needs because of the trauma that she's experienced and the addiction that she uses to manage it. And I suppose that would very much align with how the team that I work as part of sees addiction, that it's very much an people use whatever they use in an effort to manage very, very difficult emotions and feelings which they have as a result of their early childhood trauma. And that's why I think that childhood trauma is so central to the whole process. And I'm delighted to talk a bit more about that today. So what has gone on? So the lady I saw in A&E is not far off my own age, and what has gone between us, that I suppose the height of my dysregulation is not being as polite as I normally would be with one of the nurses in charge, whereas she's in A&E and completely dysregulated and unable to manage her needs. And I think certainly the way I would have been taught about it in medical training as well, it's kind of, you know, her choice, and she's a bad person because she's addicted to things, and she's rude and she's aggressive, and I'm a good person because I don't do those things, and that they are kind of random, unfortunate events that happen to people. But I think when you work in this area, you see that it's a very clear and predictable sequence of events that makes somebody very vulnerable and exposed to developing addiction and having these kind of needs. And obviously it's not a inevitable outcome, but there are definitely factors that make it hugely more likely that somebody will struggle with addiction in their life, that I think as a society and as a health system we don't really consider when we're trying to meet the needs of those adults. So there's a range of things that happen in between birth, when both I and the lady that I'm talking about were hopefully very cute little babies. There's a range of things that bring us to these different points. But I think really central to that is the experience of childhood trauma, its effect on how we perceive the world and how we behave. And then addiction to alcohol and drugs plays a huge part in both causing the trauma that people experience in their childhood, because frequently their parents or their caregivers are in their own cycles of addiction and trauma, and then societally how we manage these things. So trauma has very profound effects on the brain. And what trauma is, there's loads of different definitions, but basically it's an experience in which the person who's experiencing it feels unsafe and overwhelmed. And obviously when you're small, that happens much more easily. You have way fewer resources and different ways to get yourself out of situations or to think through situations than you do as an adult. But what happens if you're repeatedly as a child exposed to these dangerous and frightening situations that you don't have control of is at least two or three things. One is that children, because they need to stay bonded to their caregivers, they will take on the responsibility for what they're experiencing on themselves in a very different way to adults. So if children are neglected or abused, they usually interpret that as there's something wrong with them and they work harder or they need to behave differently to get their needs met. So it's internalized in a different way. It also switches on the amygdala, which is the danger sensor in the brain. So I think the people we work with, it's like they have a fire alarm or a burglar alarm going off full intensity most of the time. And you can imagine yourself how wearing that constant sense of danger and anxiety is. And I think that's where a lot of people resort to drugs or alcohol to manage that sensation. And then it also affects your frontal lobe, which is the part of your brain that gets you to basically behave like a grown-up. It doesn't work too well in adolescence. I have a 16-year-old, but it hopefully works well in most of us as adults. And it's the bit that does planning, that tells you that even though you feel like losing your cool, you're better off staying, behaving calmly. It helps you do kind of complex situations, weigh up pros and cons. And if that bit of your brain isn't working properly, it's very, very difficult to navigate the world. And trauma leaves all of these deficits or changes in the brain. Now, the brain is a really plastic organ, and these are all potentially reversible, but it's definitely not the same starting point brain-wise for Bridget entering adulthood as it is for me. Our brains are wired quite differently. I want to talk a little bit now about what we do and what our service is, and try and explain it a little bit. So the link between poverty and ill health is a very old one. So the hospital where we work, it initially was a foundling hospital, and then it was a workhouse. So poverty and trauma and addiction and illness, they're all inextricably linked. Hospitals or in healthcare see a higher level of trauma and addiction than would be there in the general population, because there are multiple factors that link those things together. But people who are in hospital in the main would have experienced much higher levels of poverty and trauma and addiction than the general population. And we also work in a hospital system which is really underfunded, overstretched. ED in particular, the emergency department, people are on trolleys in the corridor. It's very, very stressful for anybody who's a patient there. It's very, very stressful for anybody who's working there. And it's an environment in which it's very hard for anybody to stay calm. Dublin has a long-standing history of poverty, or Ireland in general has a long-standing of poverty and trauma resulting from English colonisation. So Dublin had the highest childhood mortality within the Commonwealth in pre-famine years, so higher than Calcutta. So that tells you a little bit about the legacy of what we're dealing with. And we're also in the middle of an absolutely horrendous housing crisis, where when we started working, the numbers of homeless people in Dublin, I think it was about 2,000 or 3,000. We thought that was absolutely terrible, and it's now 10,000. So those numbers have just increased. So we're really on a kind of a perfect storm of all these different factors that are pushing people to the edges of their collars. And being homeless or otherwise socially excluded, and I'll talk a bit more about that in a minute, it really makes people sick. So this is just very simply, we compared how many days in hospital, how many ED attendances to ED did you have if you were housed in our catchment area compared to homeless. And you can see there's a massive increase in needing to come into A&E and needing to come into hospital if you are homeless. But the outcomes are much worse. So, nearly half of people who were homeless who were attending our A&E in 2017 were leaving before they were fully assessed. It's a huge amount of risk there. So there are people in that mix who've had head injuries, brain bleeds, diabetes, all kinds of things that they really should be able to stay and get assessed. And a lot of people were leaving hospital before their treatment was finished, so over a third. So really showing that mismatch between what was kind of on offer, what was available in the hospital, and what the people that we work with need. Another important thing to consider in trauma and frailty and homelessness is this concept of frailty. So usually in a hospital setting or in healthcare, we would see frailty associated with aging. So as you get older, you get more and more frail. The age that happens depends on multiple things. But usually you'd be seeing this in people in their 80s and 90s. And what we were finding was that we were seeing really high levels of frailty, multimorbidity, needing wheelchairs, needing Zimmer frames, having trouble with their memory, osteoporosis, in people in their 40s and 50s. And again, the healthcare system that we work in, all the services that meet those needs are for people over 65. So, the lads that we work with weren't eligible for those things. So again, that mismatch between what's on offer and what's available in the healthcare system. And so really what we were seeing is, if you're talking about equality, you're talking about everybody having the same starting point. And what that doesn't account for is that some people have more resources, whatever they are, height, money, health, than other people. So if you want to have equal outcomes, if you want to have everybody living equally long or aging at the same rate, you need to give some people more support than other people. But actually what we do in society is we tend to disadvantage those who start out with the least. And this is leading to this phenomenon of structural violence, basically, where choices that we make as a society about who get what access to resources mean that we are left with some people who have very, very difficult lives and who end up suffering a huge in a preventable way. Like the lady who going to age 37. And we know that poverty is bad for your health. So poverty by itself, like a given age, So if you're 30 and you in a poor area, you're twice as likely to die as a 30-year-old in a rich area. The same if you're 90, obviously it's a different chance of dying in the next year if you're 90, but it's still twice as high if you're living in a poor area. And this would stand for alcohol addiction and problematic alcohol use. It's very socially patterned, so more affluent areas will have less problem alcohol use and less alcohol addiction than poorer areas. However, what we're talking about and what our team work in is social exclusion. So that's when the problem isn't just poverty, the problem is all these other things laid over it, and particularly focused around experiences of neglect and abuse in childhood. And we call that social exclusion. And that may be homelessness, that may be drug addiction, that may be people who are in prison. It manifests in different experiences. But basically what it is that series of very difficult life events that tend to happen in this very predictable fashion. And if we look, so you're probably maybe twice as likely to have an alcohol addiction if you're living in a poor area. If you're homeless, you're 8 times more likely than the general population to have an alcohol addiction. So it's not evenly spread throughout society. And your chances of dying are about 10-fold higher. So the average age of death for a homeless woman in Dublin is 38. That for a homeless single man is 44. So we're talking about not just a couple of years of life lost, we're talking about multiple decades lost. And that would very much be our clinical experience as well. We see a lot of young people dying, potentially preventable deaths. And unfortunately, then that's allied with the worst access to healthcare. So if we gave everybody the same access, we'd still be leaving people short because the needs are much higher for certain people than it is for other people. But actually, what we do is the reverse. So the higher the level of poverty, the higher the level of disadvantage, the poorer access to healthcare. And that might be around the number of GPs per capita in Finglas being much lower than the number of GPs per capita in Blackrock. It might be lots of other forms, but so it's called the inverse care law. So the more you need healthcare, the harder it is to get it. So really a bit of a perfect storm. And if we try and look underneath all of that to see what's happening, to see what's happened in the difference between myself and Bridget, I think it's important to start back in utero. So babies who are born to mums who are experiencing a lot of psychological stress and trauma, the placental function of the mum isn't as good as that of mums who are in more stable and supportive circumstances. So babies are being smaller and more early. And then early childhood, you'd be seeing very high rates of diagnoses of attention deficit disorder, oppositional defiant disorder, and difficulties engaging in school, early school leaving, and then frequently what happens then in early adulthood is prison, homelessness, all of those very, very difficult experiences, and then culminating in aging and death. So this pattern, this disadvantage runs right throughout the life cycle. But we're talking today about adverse childhood experiences, and this is one of the ways of looking at them. So this has 10 different adverse childhood events, so you can see what they are there. And again, these tend not to run in isolation. So if you have a family in which your parents are, in the throes of their own addiction and mental health difficulties, well, then you don't have the same, I suppose, a protection potentially from people in your community who may be seeking to exploit children or abuse them. And that's frequently what we would see, is that there are very, very high levels of very serious abuse concentrated in this small number of people. What these don't capture is community levels of dysfunction, and I think that's a really important variable. So growing up in a community in which there is a lot of violence and trauma going on, so where you may be seeing people being shot and people experiencing violence in your community, that also has very profound effects on children's sense of safety. And in general in the population, about most of us have 1 or 2 ACEs, and it would be very rare, less than 10% would have 4 or more ACEs, 4 or more of those really adverse events. If you look in populations that are socially excluded, so people who are homeless, people who are in prison, people who have drug addiction, you're talking 80 to 90% having experienced 4 or more of those very severe adverse childhood experiences. And I think that's something as a healthcare system we don't recognize. So if you're a healthcare provider and you see somebody who is homeless or in prison or addicted to drugs or has severe alcohol addiction, you really need to assume de facto that they have experienced very severe adversity in childhood, and that their interpretation of what's going on will differ significantly from what you might expect to be their interpretation. And we don't factor that in, and I think that's really negligent of us as a system. system not to factor that in more. So simple things like being asked to wait, or being told it's not your turn can be experienced as very punitive. And then how we tend to respond to drug use or shouting or displays of impatience, for example. Impatience tends to be very punitive, and we forget that we think we're talking to an adult, but actually brain-wise who we're talking to is a small child, and our responses are being perceived in that way. I think something that we would see a lot is around aggression. So it can be very different if you have a 2-year-old having a temper tantrum. Everybody recognizes what that is and knows how to handle it. If it is a 40-odd-year-old man with traumatic brain injury and cognitive impairment who's shouting because he can't move his wheelchair or can't get what he wants, that will be perceived as being very aggressive and handled in a different and perhaps less productive way. And I think this is really, I think, the key point of this talk and the key point of what I want everybody to take from this, which is that addiction to alcohol or drugs is not a choice that people make from an even playing field. So your chance of being addicted to drugs, which in general in society is perceived as, you're a bad person, you've made bad choices, that is 8-fold higher if you've experienced more than 4 adverse childhood events. So 8 times more likely to have. So when we punish people or make certain judgments about people because they have used or have used drugs, I think we're really not considering the effect of early childhood trauma in that, and I don't think that's fair, and I don't think that's a productive way to look at it either. And then there are loads of brain changes that happen with adversity. So I always think that trying to find housing in Dublin if you're homeless is probably one of the most frustrating things you could ever do. So you get this HAP payment, which is about €1,000 a month, and that isn't enough to meet the current rental rate, nor do landlords want to take it. So you have this repeated defeat. You could go to 1,000 viewings and be turned away from all of them for a tenancy. And so loss of social status or repeated defeat affect the brains of animals even in the absence of alcohol and drugs. And so what you can see, for example, in mice is losing social status, being kind of affect how the brain works. They make your blood-brain barrier, which should protect your brain, and they make that leaky, and the mice display what's called kind of defeat mode. So they basically stick their head in the corner and don't feel like getting up and doing anything. So sometimes when I hear that a patient didn't turn up for outpatients or didn't do what they're told, I wonder how much we're considering these variables when we're making those judgments about the patient. And again, addiction, very, 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 very mediated by social experiences, by psychosocial experiences. This is work done in monkeys, and in primates there's like a dominant and a subordinate monkey in any particular setting. So you can tell who's who. The guy who's on the top of the pile, he gets to have his fleas picked out by the other fella, and the other fella is having to pick the fleas out. But your dopaminergic system is a really important part of your brain that drives you to do things that are productive, like eat and reproduce and all of those things. And you can see that in the subordinate and the dominant monkey, the dominant monkey, when it's by himself, he has a little bit of dopaminergic activity going on. He's not feeling too bad. And the subordinate monkey has a little tiny bit of dopaminergic activity, not a huge amount. That's kind of bright yellow. When you put them in together socially, dominant monkey feels great about himself and subordinate monkey feels absolutely crap. So his dopaminergic system isn't firing. And what will guarantee to fire that, which we're all driven to do biologically, is things like alcohol, drugs, and certain risk-taking behaviors. So again, kind of giving us a bit of an understanding about how addiction is very much driven by our sense of ourself within society, within social settings, and how really it's not an even playing field in terms of people's likelihood to end up addicted to substances. And then I think this also compounds the problem. So this is our deservometer, and I think I've already alluded to it, but who deserves what? Who deserves to go to top of the queue in A&E? Who deserves to get the extra cup of tea? Who deserves to get an extra bit of time in outpatients? Who deserves services set up for them? And that's all societally conditioned decisions that we all make. But being addicted to alcohol or drugs is a pretty good way to score red on that deservometer and not to deserve services. And I think hopefully I've convinced you that, saying that people who have an addiction are less deserving is not really fair, because it's very much linked to their earlier life experiences. So what do we do? So we have a specific team. It started with myself and Anne-Marie Lawley, who's the nurse manager on our team. It was the two of us back in 2016, and now we have a fantastic interdisciplinary team with lots of doctors and nurses, and a fantastic addiction person-centered care lead, who's the token male in the back. He's sitting here beside me, so I'm slagging him. And we would just really try and meet people where they're at, and people's experiences in their early life and their early life traumas, and absolutely central to how they experience the world, and so it needs to be central in how we respond to them. And we work with people at all stages of addiction. So we'll do harm reduction if people aren't ready to stop using or drinking, and if they are, we will help them in every way we can to get and maintain sobriety. And what we try and do is provide integrated, low threshold, trauma informed, interdisciplinary, high fidelity care, which is basically we don't give up, and you can tell us to fuck off and we will come back and still see you the next day and probably like you all the more, because we have a soft spot for the difficult ones. And yeah, really that's me for today, Sheila. Thank you for all the work that you're doing. I think, we underestimate how important national government policies are. And I didn't mention that in terms of societal risk factors for addiction to alcohol or drugs. So availability of different ways to manage our emotions is so important. And, I suppose if we put the same amount of funding and support into gyms and sports activity and counselling and arts clubs and all kinds of things for people, I think we might have to deal less with the fallout of alcohol addiction that we deal with every day. And I'm going to dial off now. Thank you so much.
That's very helpful, and I really do appreciate, Clíona, your contribution there, and just explain to the audience that Clíona is actually on her way to a funeral, and which is why she firstly had to do it via her phone, and why she hasn't been able to just stay on for extra questions at this point. So thank you very much for that, Clíona. And I'm going to move on at this point to our second speaker of the morning, because we're just joined here also online with Richard Hogan. Now, so Dr. Richard Hogan is the Clinical Director at the Therapy Institute. And Richard is also the author of Home is Where the Start Is. And in fact, that's actually the title of your own talk today. And I think that you're planning to focus on the impact of addiction on child development. So Richard, I'll hand over to you at this point. Thank you.
Thanks very much, Sheila. And that was a great presentation by Clíona there. I suppose what I'm going to talk about here is, I've been a teacher, I've been a principal, I'm a psychotherapist. I write for the Irish Examiner. So, I grew up in a family where my father was a journalist for the Irish Times. It was the head Munster correspondent in the 1970s and 80s. I want to speak about my own experience growing up, because I never really mentioned it to anybody for a long time. And I never really spoke about it until I wrote Home is Where the Start Is in 2023. And in that, when I was writing that book about, the family you come from, the early attachments, your relationship with your peers, your relationship with where you come in the family, I was looking at all the idea about the story that we tell ourselves about who we are, where does that come from? And as I was writing that book, my own story started to come up, and I started talking about my own, it just started to happen, my own child. I was writing about my own childhood and my own childhood experiences. And as I was writing the book, which is always what happens when you're writing a book, a different book emerges. You have an idea of a book, but a different book comes out of it. And at the end, you kind of feel, oh my God, that was the book that was waiting to be written. I didn't realize that at the time. And so I wove my own story in and out of this book that was about the theory of how to thrive in life. That was really what I was trying to get to, that we all come out of messy families. Here's how how you can thrive. Here's some ways of dealing with maybe some early childhood experiences that might have been adverse. But as I was writing the story, my own story kept weaving into it. And I started the book, with an anecdote. When I was 15, my mother asked me, did I want to go and see a psychiatrist because my mood was low? And I thought this would be a great moment, because I hadn't spoken to anyone about what has been going on in our family. I had kept that secret, like most families are. Families are very secretive places. There's nothing more complicated than the family system. There's nothing more complicated than the family you come out of. And so I held that secret like everybody else holds a secret about their families. And this was like early 90s. And we were in the psychiatrist's waiting office. And the secretary said to me, no, I can't remember the psychiatrist's name. He'll see you now. And so I went off thinking this is going to be a great moment where I had images of myself sitting down on Freud's couch, pensively recalling my troubled childhood to a very interested and engaged, psychoanalyst and all the rest of it. And as I was going in, my mom just leaned over and said to me, "Don't tell him about Dad. He knows Dad," right? And we have spoken, myself and my mom, we have a very close relationship. We've spoken about that moment for many, 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 many years over the course of my young adult and my middle age now. And so I put that in as the opening anecdote in my book, because I thought that was such an important moment. Because when I went in and sat down with the psychiatrist, the first thing he said to me is, "Your dad's a great writer." And so immediately I was straitjacketed, and I never felt more hopeless, because if professionals were going to be misted by my father's profession and his career and his status, what hope had any of us? Because I thought when I was going there, maybe I might bring the family, maybe the family might get the help it needs, because the reality was we were living with someone who was really struggling and really heavily stuck in addiction. We were living with somebody who had been caught, like many people, in addiction and alcohol. And it was something that really troubled my early development personally. And then as I moved, I never talked about that. And then as I moved into my adult life and I started working in schools and I started to, write for the paper and all that. I remember being at I think it was like 2011 or whatever was the Heineken Cup. I remember standing there watching this match and seeing all the Heineken flags in kids' hands. I remember thinking, like, Jesus Christ, this is like George Orwell. It's like it's some sort of Orwellian nightmare, dystopia. All the kids are there with their Heineken and their Guinness and all the rest of it, waving these flags in their hands and indoctrinating them into this world of alcohol. And this is before I ever said it to anyone. And then I started writing about it for the Irish Examiner, and I started getting a lot of pushback from a lot of people, right, saying that I shouldn't be saying these things, I shouldn't be talking about this stuff, because what I was trying to do is try to crack some of the cultural stuff that's in there about how we normalize drinking. Drinking is the most normalized drug we have, and there's a social aspect to it, and we use it, and it's in the ads, and it's always promoted as this recreational, happy inducing kind of thing. And that was so incongruent to the family that I grew up in and the life that I had as a child. What I had as a child growing up is that alcohol was an incredibly destructive influence on someone who was talented. I could see my father's career, who was a very talented man, sink. I could see his life sink. Eventually, my mom had no other choice but to separate from him, and I just saw his life collapse. And I saw all his friends who were also stuck in alcohol. I saw all their lives collapsing very early, and I was struck by this. As a 19-year-old, as a 20-year-old, I was really struck by the devastation that alcohol brings into people's lives and how normalized it is as a drug. You'd never have the heroin cup, the heroin Six Nations, and when I talk in schools about that, and they can't get their head around that idea. When I talk to young adolescents about how it's normalized and how it's presented to you as something that's harmless, in fact, actually promotes social connection and all the rest of it. But there's a huge aspect to this that we don't talk about, and that we get pushback from vintners. I get pushback a lot from these people when I write about those exact ideas. I get a lot of pushback from it, but I've lived it. I'm not talking just about someone who's worked in schools and gone into psychotherapy and worked with families, because I've done that too. But I've lived the experience of alcohol and alcoholism, and I know what it did to me. And I'm only speaking for myself, here. And for me, very early on, it really ruptured senses of self and it was only, I get kind of emotional when I talk about it because I don't talk about it that often. And it was only when I was on Brendan O'Connor that that he said something to me that really got me. He said, I was talking about my book that was coming out, and Brendan said to me, "Are you a tribe, do you think, children of alcoholics?" And it was the first time I realized I belonged to a group of children out there that had grown up with addiction. And then I work, and I'm very friendly with Katrina Sullivan, who wrote the book Poor. And we would talk at length about our experiences growing up. And she would say to me often, which often gets me, she grew up with parents who were stuck in, heroin addiction and alcohol. And she'd say that the alcohol phases were the worst phases, because alcohol is a depressant. and it creates, you know, aggression and stuff. And so as a kid growing up, you never knew what you were going to get coming in the door. And that to me was the most troubling thing. It could be all perfect and it could be all fine. My grandmother lived with us and she was a great Cork woman and we had great, and I'd go into her and I'd play the guitar to her, and you know, we had all that lovely kind of stuff. And my mom was a very supportive and caring person, trying to hold this whole thing together while she watched her partner collapse into addiction. And you know, that I always think about the tectonic plates, you know, they were never stable. The ground was constantly shifting. And the image that really struck people when I wrote about it in my book, and so many people have written to me about it, I said when I was coming up the estate into my, you know, when I was coming up this hill into my estate in Cork and Douglas, I used to stand on my tippy toes to see if the car was home. And if the car was home, I'd get this sinking feeling because anything could happen. And I didn't think about that image as I wrote it. I just wrote that image into the story of my book. And the amount of people who handwrote me letters saying I did the same thing. I looked up to see was the car there. I constantly checked to see was the car there. I would phone ahead to see was he home or was she home. You know, and so that image of like looking up to see if my father was home was something that was a massive part of my childhood, because you never knew what you'd get. You go in the door, it could be fine, but I was in tune, like Clíona was saying. Trauma, it activates this, you know, the way I always think is it's like the tiger in the car park is the image I have. Is like when you go to the zoo, you know, your frontal cortex allows you to process the fact that you're safe because you have glass in front of you. But if I'm out in the car park and I see the same tiger next to me, all of a sudden it doesn't even get shot up to my, you know, cerebral cortex. It stays down in the warning system. And when you grow up with in addiction, it's like the tiger is in the car park all the time, and you're constantly looking around for threat and to see if you're safe, and it heightens it. And it heightens your alarm system. It heightens your sense. And I've seen this so many times, Sheila, you know, sitting clinically, and it really gets me. I worked because I've spoken about my own experience with this, and I don't like speaking about it. I'll be honest, like, you know, I don't like speaking about it, but you know, we have to speak about it because I've got a platform, and it's important that we do speak about these things. I don't think any of us want people to have a look into our family, you know, with a microscope, because we're secretive and our families are secretive. But there's so many families that are struggling with alcohol addiction. You know, and it's so normalized. It makes me so frustrated. And I do meet the government a lot, and I do speak with politicians a lot, and I do say this to them. We have to stop advertising it. We have to stop promoting it as some sort of social, you know, cohesion substance. Like, you know, there's nothing wrong going for a pint, meeting your friends, but let's be honest, you know, who does that really? You know, it always ends up, generally in my experience, moving towards something else. And in my childhood, I could see my father using it to satiate some difficult early childhood experiences. And so when I was a teenager, I viewed him very linearly, like, you know, bad guy, good guy kind of thing. But as I got older, I started to see his complexity in his life and how complex he was as an individual, and how he leaned on a substance to ameliorate and help him with some early childhood adverse experiences. And that's what happens. And that's the positive psychological feedback loop that is a substance. The thing you use, this is what happens. The thing you use, right? The thing you use to satiate negative feelings or emotions is the thing that spirals your life further into disorganized chaos. And so that you become more emotionally unstable. So you're leaning on it more, and it goes around and around and around in this very terrible loop that you can't kind of get out of. And for years we lived in that, and it wasn't until, and that's why I think talking about it is so important. I went to Rochestown College, Cork, and we were on a retreat, and they brought a father and their son in to talk to us about addiction. This was like probably 1990, 1991. And I remember the son saying something about he lived with his father, who was an addict, and the father was there who'd gotten sober, you know, and had gone to Ashery and gotten sober. And I remember thinking that was the first time I ever used that word, addiction, because in those days you'd say fond of the jar. You know, that was the language. He was fond of the jar. I mean, he, you know, that was the kind of the diminishing of what the family was living with. Yeah, he likes his drink, right? You know, so it was the first time I had the word alcoholism. I remember going home to my brothers and saying this, you know, and it was the first time I had language for what we were experiencing as a family. And if there's any questions there, Sheila, you can throw them out there. Don't make sure you ask there. If anyone asks a question or if they want to ask me something, make sure you ask. And so that was important, getting that language for what we were dealing with. And it's spiral and spiral and spiral. And I think that's the thing about the positive feedback loop. It just goes down. The bottom can be kind of a kind of an endless concept with an addiction. Sometimes you don't reach it. It just keeps going and going and going, you know. And it disrupted my early attachments with people and relationships. I would love to hear more of. I don't see the end of that question there, Sheila.
Yeah, and indeed, there's a lot of questions actually. Just
just ask them. That's fine. Yeah, just ask them away.
Owen, maybe if you're just looking at that actually, because I know you have your computer open. If you want
actually water, it looks like I'm drinking something more powerful. Actually, a big bottle of water in a hotel room. Is there a question, Sheila? Do you want to ask there, or
there's a few questions have come in, Richard. So Eileen wants to thank you for sharing your story and how helpful it is, and she points out that it's important to speak about the secrets that exist within families all over Ireland.
Yes.
And how our experiences help us to turn up for those who come into counselling rooms with a similar story. So she just wants to offer some thanks, and Irene as well. She says she can identify so much with your story. Stephen made a good point. He said, is there any human that is not an addict? Are we not all dopamine addicts? Caffeine, nicotine, alcohol, all of these sources. Is sugar in addiction?
Well, I would probably disagree with that one. Yeah, I think dopamine does run a lot of our behaviors, but I don't think dopamine in a lot of ways will sink your life like alcohol or bring, you know, when I see my father, he was a good guy. He was a good guy by all accounts, you know. I don't think anything. I think alcohol warps your personality. I think it brings out the worst latent stuff that's in there, and I think it. And I think, you know, the evidence is all there. It can destroy lives pretty dramatically. I don't know about caffeine or coffee. I know what he's saying, having read Dopamine Nation and all that. But yeah, I just think I think a substance, anything that's a positive feedback loop, a substance that changes your personality, is particularly problematic, and we should stop advertising it.
Yeah.
Yeah, I just have a question, 3 questions. One is from Melanie, then I'll pivot to Marion, who can ask it in person.
Sure.
And so Melanie's question is, she grew up with she wants to hear more about ACOC as a parent, and she grew up with an alcoholic father. Her father is no longer a drinker, but she's the only person in her family getting therapeutic support. She's never been addicted, but she certainly didn't deal with the issues properly until it got to when her kid was 4. Her child is now 11, and she's read that addiction can skip a generation, and she doesn't want that for her child, and she's wondering, how do we stop that? She assumes it's not inevitable.
Yeah, I would say just watch that. That's a little bit of early childhood trauma there, you know, in your response to your child. There's no, you know, I don't think that, you know, there's this, you know, inchoate latent gene there going to jump out in your child. The biggest gateway into addiction is early childhood experience. It's not smoking grass or drinking alcohol. That's not the gateway into drugs. The gateway into drugs is childhood experiences. It's attachments to your primary caregiver. Everything in your early attachment as a child is all about the proximity you get to your parent. And so if that's disorganized, or if that's avoidant or anxious, that will cause a bit of a rupture in how you experience and receive love through your life. So there's the thing to be watching out for. And so the fact that you're worried about your child and all that kind of stuff shows that you're kind of, you know, you're very involved in your child's life. So try not to think like that. Let your child has to grow up and develop and experience life and all that kind of stuff. You can't be worrying, will they be an addict like that, because that will position you to be probably overly coddling them and overly protecting them, and they'll resist you massively when they hit 13 and 14. And so I would say just try to relax about that. That's just a bit of your own trauma, and that hasn't been dealt with, or that maybe wasn't validated as a child. And I would say go figure that stuff out. Just because you're the only one going to therapy doesn't mean that you're the only one who needs to have a therapeutic conversation. You know, and so you can often feel the stigma that, well, why am I the only one who is impacted like this? Well, you don't really know, to be honest, and the likelihood is that you're probably not. But we don't process information across the species in the same way. And so when one child can see the father throwing a plate through the window and not be massively impacted, another child could disassociate and have real difficulty with their emotions there. So try to be compassionate to yourself and relax around your child there.
Richard, thank you so much. Oh my goodness, just listening to everything you said, I completely agree with, especially your discussion around the environmental factors, which Alcohol Action Ireland has been trying very hard for years to, to be heard in that space. But I was just thinking about, this issue is like mercury. It's very hard to really grasp. We have the children's side of things, and then we have the adult side of things. And it's just when Brendan O'Connor said to you about, are ye a tribe?
Yeah.
I think the amazing thing is that every time somebody like you speaks, people identify very, very significantly. So I keep thinking as well about, I don't know if you know Claudia Black from the States, who says the 3 golden rules of the alcoholic family are don't talk, don't trust, and don't feel.
Yeah.
And I'm just thinking about that for the early 20s, like, for many of us, the mental health implications of having grown up in a family often happen in the early 20s when you're starting out in college or when you're, beginning relationships or whatever. What would you say to, students, let's say, or people in their 20s about the issue? Because the reality of what you've grown up with suddenly begins to hit.
It does.
And there isn't a voice out there that says, you're welcome to our tribe, because nobody wants to be associated.
Exactly.
So I was just wondering what your thoughts are on that.
Yeah,
Richard.
no, it's a great point, and you're right. And I even found it hard when I wrote that book. I was so nervous when it started to come out, and then it wasn't until I got the reaction from other people who had gone through it, then I went, oh Christ, that's why I wrote it, right? I kind of relaxed about it then, because I was actually very nervous, because as I said, particularly Irish families, they're so secretive. Now I did ask my family, can I tell the story? Can I tell my story? And they were like, okay, go for it, because they're very private people, and I knew I was telling their story by proxy by telling my own story. But what I'd say to young people there, if I could go back to that 20-year-old me who really struggled in his 20 years at 20, oh, geez, when I think people often say to me, God, wouldn't you love to be 20 again? And I'd say, Jesus Christ, not a chance. Not a chance. I had just caught my father having an affair. I was dealing with trying to figure out what to do with that in the family. The family was collapsing all around us. My grandmother had broken her hip. I took time out of college to kind of help her convalesce. I was basically her care for no, that was not a good time to be a 20-year-old. So I was dealing with a lot of stuff there, and it really weighed heavily on me. But it also made me resilient in some ways. When my youngest daughter was born, she had a very rare condition there in 2017, and I remember standing outside the Coombe, and the doctors had told us very terrible news that it wasn't going to be successful and all that. And I remember thinking, oh shit, I wonder, have I got the strength to manage this now? And I remember just having that thought, well, you've been down this road before, and you managed it when you were younger, so I think you might have it. And I just relaxed in that moment, and thankfully she's 7 and thriving and full of life. And so, but that early experience stood to me there. I was like, well, you've been through this, you've been through some shite before, so here you go again. And so you maybe you do have it. But what I'd say to a 20-year-old, if I could talk to myself, is go and talk to somebody. Your family is such a secretive place, and families, you can't talk with your family about these things in some ways. You need to talk to someone who's outside this family and doesn't have skin in that game. Go work it out. Figure out the things that you tell yourself about who you are. I would say that's a huge thing. Figure out the story that you're telling yourself. I was telling myself a terrible story, about my ability, about who I was, about fidelity. I believed I developed a very destructive paradigm that all people are cheaters and all people will let you down, and you can't trust any men. I had that idea that men only fucking let you down, and there are none of them that are trustworthy. All of these things I had very early, and I closed off as a person. Like, you couldn't have reached me at 2021. I closed off. I was in a relationship with someone who I really liked, and I broke off that relationship because I just didn't want to be around anyone emotionally or anything like that. And so it shut me down for a while. And then as I started to figure this stuff out. No, I didn't talk to anybody successfully. When I went at 15, that turned me off psychotherapy for life and psychiatry. But in some ways, it motivated me to become one. But that I would have been somebody I needed to be in that room, So I would have been the psychotherapist that I could have gone into and had a conversation with somebody that might be able to kind of, help me with my thinking and my thoughts. And that's kind of the work that really excites me now.
Yeah.
Someone comes in and tells me that they're not that smart, and you know, we're living with addiction, and I'm the stupid one in the family. You know, that's the stuff that I love, you know, sitting down there with someone and really helping them to see who they could potentially become, because that was me too at 20 years of age, you know, having kind of left college and not knowing what I could do with my life and feeling stuck in a family where there was addiction and there was at times violence and all the rest of it. I felt really stuck there, and I wasn't. And it's amazing how quickly it moves. And that's what I always say to when young adults who say to me, I feel so stuck, I'll say it feels like you're stuck now, you know, but it's amazing how quickly things can change and how quickly you can get distance from something that's so awful. And you look back and you realize that actually you did a few things to maneuver your way out of it. I did myself, and my life changed irrevocably by a bit of good thinking, just a bit of better thinking, and just getting a little bit more precise about what I wanted and moving towards it. I was working in the interest of my future self. I began to stop talking so negatively to myself, and I started, you know, working towards something I wanted to become. I knew I wasn't it there, but I knew what I wanted to become, and so I worked towards it. And I think helping people to get like that, you know, and to getting a bit more precise about what they want and helping them to stop viewing themselves as somehow stuck, because I always go back to the Carl Jung thing. My childhood has happened. I can't change that. But I can change how my relationship with it. I can change how I talk to myself about it. I always think of the Carl Jung phrase. You know, Carl Jung's a great psychologist. You know, you're not your childhood. You're not what happened to you. You're who you choose to become. And that can be frightening for people to think that they have this power and agency and autonomy in who they become. But we all have. And we, you know, and then I started to stop viewing my father also in this linear way of the villain. I started to see him in the matrix of complexity that he came out of. And I started to build a life that was more positive. And I remember saying to myself very clearly, very young, no barman will ever know my name. I had that image because everywhere I went with my dad, oh, hey, Dick, how are things? Every barman knew him. And I remember thinking, no barman is ever going to go, hi, Richard, as I walk into a pub, my kids with me. That's never going to happen. I'm never going to be a feature at a bar where my life is there. You know, my life was, I always wanted my life to be with my kids. And I wanted them to come home and to be excited at the fact that I was coming home. I didn't want them to dread me coming home or, you know, running upstairs to get away from me. And so when I sit down sometimes and the kids come running in and give me a hug and watching TV, I'm like, that's it. Now it's fixed. I fixed it. They never know shouting. They don't know aggression. They don't know, you know, plates going through windows. And sometimes my daughter will say, Dad, you're raising your voice. And I'm thinking, dude, you have no, I don't say it. I think it, you have no idea what a raised voice sounds like, you know, and so they don't live in that experience. And that's healing something from your early childhood.
Yeah. Richard, thank you so much. You mentioned that this platform, I really hope you'll join us again for these discussions. It's fantastic what you've revealed to us this morning. Thanks a million.
Thanks very much, guys. Appreciate it.
Richard, I just have a few more questions.
Yeah, no worries.
I take them. So Kelly says that she works with a young person growing up with a similar childhood where her primary caregiver is an ex-alcoholic, but she's struggling to connect with her mother now. In retrospect, what advice would you have liked to receive in relation to support from a youth worker? That's one. Breege, do you want me to ask all three, or do you want to take one at a time?
I'll take one at a time. Yeah. So I suppose when you're a teenager and all that, it's, you know, it's what I would be trying to do when I'm working with an adolescent is trying to keep because they can, you know, their brain isn't so fully developed yet, and they do like to think in kind of black and white and good and bad and all that. What I would try to do is I wouldn't try to force them towards anything there. I'd try to hold it and try to like unpack all of their feelings around what kind of a relationship would they like to have and what kind of relationship do they have currently. And I'd try to get them to see their parent in a far more broader way of looking at them than just an alcoholic or an addict. I try to get them to see, and I try to delineate some of the stuff that they do with their parent, because the brain is kind of goes towards negative and I don't have any relationship. That's not necessarily true, I'd imagine. And I try to pick out where do you have a relationship, and what is the relationship like when it's going well? And I try to get them to focus in on that, so that when they're having a nice moment with their parent, that they can actually become more aware of it and conscious of it, and so that they're not saying, oh, this is all terrible. I would help them with that a little bit, because they can be quite focusing on the negative and what is not present currently. And I just allow, you know, and a huge thing working with adolescents, I mean, what is a great therapist is probably somebody who allows you to have a relationship you don't have yourself with your family, and you sit there and have that relationship with them, and allow them to speak and validate their feelings for them, but again, help them to be less narrow in their concepts of what's happening and get them to focus in on what's going well in that relationship. All right.
Brilliant. I have another point here from Bree. She says a very interesting take on each family member's different response to a parent who has alcohol issues. She says she's one of six, and each of us will have different recollections to various events when we were younger, that involved alcohol misuse. And I suppose it's a point you intimated in terms of writing your book. I suppose if you could just speak to that point a little bit for Bree,
Yeah.
I'm sure she'd be delighted.
Yeah, no, actually, Breed, thanks for that. Absolutely. We don't process information and stimuli across the species the same way. I mean, that's what family therapy for me, when you sit down, you talk with a family, you're getting everyone's perspective on what happened or whatever the issue is. And that might be six different realities, but you're kind of going, well, there's only one reality here. Well, there's not, it's how you perceive it and how you internalize it and how you then kind of like, interpret it. And even when you come in the family there, Breed, if you're the youngest or the eldest, that's going to impact on your experience of addiction in the family too, massively. And yeah, so I like, my book actually goes through all of that, my book, and I'm not trying to sell my book here, but it does go through all of that. And it goes through the different levels in the family, the different ages in the family, and the different kind of ways of experience it. But again, yes, we all process it differently, and it means different things at different stages of your life, because you start to process it at different times, and different things are going on for you personally, and your childhood is always quite close to you, and so you're analyzing it all the time, particularly if it's unprocessed. And so I would say, yeah, absolutely. We process it differently, and understanding what it meant for you, and try not to maybe get annoyed at your siblings who don't see it the same way. Just know that in some ways that could be their defense mechanism, to kind of almost managing it, that they might block it out a little bit, or they might disassociate from it a little bit. And so they mightn't want, to acknowledge it. For them might be profound. And so just be careful about pushing people to align with your experience, but just know your experience is absolutely valid, and that's what happened for you.
Yeah, and just building on that, Evelina raises a similar point, and she's just wondering if you could mention some of the strategies a family might incorporate to deal with or around alcohol addiction in the family system, on that basis of people perceiving things differently growing up.
Yeah, well, what's the question there? I'm trying to figure that out there.
Yeah, so Evelina says she's noticed similar within her family of their time growing up, they view it very differently. She's just wondering if you could mention some of the strategies a family might incorporate to deal with or around addiction.
Well, you see, you might never, yeah, but thanks. You might never align with your family members, your siblings around what happened, because it might be very different at different stages of your father or mother's addiction, where whoever's the addict, there is these kind of like, ups and downs with addiction, and depending on the age you were and depending on what was going on in your life, you mightn't be that in tuned to what's going on. So you might have been more in tuned. I was quite attuned to what was going on around me. I was always looking at people's behaviors and how people were feeling. I was always in tune to that. My other brother mightn't have been like that, and so I can't force him to have the same experience as me. And I suppose when I was writing the book, I was saying to him, this is my experience here. And in fact, afterwards, he said, you were too kind. When he read it, he said, you were being very kind there. And I said, well, yeah, I didn't want to be over, I wasn't going for a public penitential here. I was just trying to express what happened to my own experience, and what, and so again, watch the desire to have people be complicit in your experience. You don't need that. You had your experience of growing up with your father or mother who's an addict. It impacted on you the way it did impact on you. Other siblings, it impacted on. It definitely impacted on them. But how they deal with it and how they manage it might be a different intervention than you do. And maybe talking about it and trying to kind of like, work it out that way is important for you. But yeah, so again, it's just like watch your need for other people in the family system to be the same as you, because they mightn't be able to be that. And so try not to view them as like, well, why don't they have that experience? What's wrong with them? They're denying it or whatever. I'm trying to pull back from that and just say, well, that's their way of processing it. That's their way of dealing with it currently. Who knows what will happen as things change for them as they go through life.
Super. There's a lot of thanks for you, Richard, and I think you'll have increased book sales after this talk. A lot of people pointed to they'll be picking up the book, myself included. Val had some words about the struggle, their struggles around addiction and so forth, and is very thankful for your words today. I just have one final question, and
Sure.
bat it away if you feel it's kind
No
of
worries.
outside the scope, but it's around zero alcohol products. Susan is just asking, or just stating, like, that they shouldn't be sold in supermarkets outside the structurally separated zones. And I suppose, in your own work or your own perspective, would you have any point to make on that in relation to the use of zero alcohol products to circumvent advertising advertising restrictions and the structurally separated zones in supermarkets.
Let's be honest, they're a little hook to get you, to remind you about alcohol. You know what I mean? It's like vaping. They have their hooks all over the place, and they're trying to, get you back in and to remind you about alcohol. And you're walking out and you see the beer in front of you, and oh fuck it, I must get some Tiger beer. It's not that you're going for the 0-0, and so a rotten hook, absolutely. But this is how they operate. I mean, this is how they operate. I mean, this is how. Burns beer, Guinness. I mean, this is how they work. This is how they're in our society. So not so surreptitiously. They're right there in front of us. They're on everything. They're everywhere. And then advertising. I can't believe. I'm sitting at home and they're advertising a beer and they're showing that life without the beer is crap and life with the beer is brilliant. And that goes against actually advertising standards. But yet they do it and they get away with it because they're constantly pushing it. They're pushing to see what they can get away with. And so placing 0-0 outside is them pushing it to see what they can get away with. And I think we should push it back in and say, no, all alcohol, whether it's alcohol strong or light, whatever it is, goes behind the fence here. And so children can walk around and not see alcohol products in front of them. But let's be honest, children shouldn't go to the dart station either and see alcohol products up in front of them. They shouldn't turn the TV and see alcohol products in front of them. They shouldn't have flags with alcohol products in front of them. We need to get stronger. And I just can't believe we still have it. Obviously, I get angry about it because of my childhood. But I think when I see other children walking around and I see this dystopian stuff around me, it really gets to me, I have to say.
Super. Thanks very much. I might just pass
All right.
to Sheila. She might have a point or two to make on that. I know she's done a lot of work in the area. So
Yeah, well, we do have a strong feelings about the zero alcohol product marketing because we do see it as a con. We see it as they're products. I mean, people will like them or not like them. That I don't have a problem with people having them, but when they use identical branding to the parent or the master brand,
Exactly.
that they're getting
It's just
around.
reinforcing it. They've got psychologists that are working on that, Sheila.
Absolutely, absolutely, they have. One last thing that I just wanted to ask you about is, you've trained as a psychotherapist yourself, and you obviously have a huge interest in this area. In your own training or in maybe training that you might be doing with other people, is this a topic that comes up? And is this something that you would maybe like to see a bit more?
Definitely. It didn't come up in my training, Sheila, really. Not too much.
Well, that doesn't surprise me because funny enough, we did a survey actually through with Sharon Lambert actually in UCC, and did a survey of mental health professionals, and about 70% of them had no training at all in this particular area. And yet we would know, and I know you would know this, that so much of people's health, whether we're talking about depression, anxiety, eating disorders, can often have their roots, back in this. So I was just interested to hear.
Yeah, and it's terrible because I think society views addicts as those down in in heroin and sleeping outside and all the rest of it. But the reality, the majority of addicts that I work with are functioning and going to work like my father did, and have big jobs, but the whole system is collapsing under it. And that's the reality, and you need really well-trained psychotherapists. I'm well-trained because I've read an awful lot around it and I've written an awful lot around it, but I've lived it, and so I kind of understand it from the perspective of a child as well and an adult. And so we do need a lot more training as psychotherapists. I think across the board anyway. I don't know, do you get that much training really working with, say, disordered eating and with addiction? So yeah, I think you're right. We need far more, we need better providers there to upskill psychotherapists so that they can work with families in a more successful and hopeful, I mean, that's the thing, a hopeful way.
Absolutely. And I think I'm so glad to hear you just, bringing that note of hopefulness. Sometimes, I find across society in general, if you mention the word alcohol, it's kind of like there's a despairing, oh, Ireland's always been this way, or we're always
exactly.
this way. There's always this always. But actually, when you look at the facts and figures on this, firstly, we were not always this way. We do change the level of the amounts in which we drink because of various factors like, price, availability, marketing. These things do change the amount we drink. But more importantly, we know that change is possible, and I think therapeutic support is a huge factor in that. And I was also very happy to hear you just talk about your own resilience and what you developed, within that, because again, there can be sometimes this fatalistic thing of, oh, well, this happened and therefore a disaster will ensue. I think, when you point to your own strengths, and no doubt part of that would have come from the supports that perhaps you received, you know,
Exactly.
through other family members, maybe being able to speak up and speak out.
Well, you learn to become very resourceful and rely on yourself, you know. That's one of the things. You learn to rely on yourself. But what can I just land on this last hopeful thing? I think teenagers today are less drinking than, you know, I think they are more interested in, particularly boys, and they're interested in going to the gym. And so I think there's a bit more positivity creeping in there. They probably might have higher levels of binging, whatever it is. But I think drinking, just drinking and all that, I think they've got less. I think it's less in the system than when I was a kid.
There has been a reduction in the overall level of alcohol in the country, and there is a reduction in the age at which young people are starting to drink. So those are definitely positives. I never like to run away too much from this, because we're also very aware that, you know, we do have very high levels of binge drinking in Ireland, and sometimes the industry is very keen to use any sign of improvement to say, oh well, sure, then there's no need for any more restrictions, or
no, definitely not.
so there's always a nuanced kind of a thing which we do. Richard, I have to say that has been absolutely fantastic, and I really appreciate you've just given an awful lot of yourself and, you know, your own insights, which is, you know, hugely informs, I think, the way in which we work, but in which I hope our audience will also be gaining from. So thank you, thank you very, very much indeed.
Thanks very much. Thank you.
So we're going to move on to our third speaker of the day, and a little bit, as I say, we have gone a little bit out of order, because in some ways Karen would have been the person who would have been setting the scene and kind of looking at this in perhaps the more technical side of things. But you know, I do find that actually anytime we talk on these sorts of topics, everything informs everything else at the same way. So I'm going to be handing over very shortly now to Professor Karen Hughes. Karen is based in Wales. She's the Research and Capacity Development Manager, this is a very long title, in the Policy and International Health Directorate at Public Health Wales. And she's also an honorary professor at Bangor University. Karen, I have been following your work for a long time, because it really informs what we would do. But you have a very broad public health research portfolio, specifically looking, I think, at these adverse childhood experiences. And you've done a lot of work on the kind of like the population-wide research that I suppose helps inform the way we think of this from a public health perspective, and the kind of things that would be out there. So the title of your talk today, Adverse Childhood Experiences, Life Course Impacts and Opportunities for Prevention. So I think you're going to kind of just home in on some of the areas that we've been touching on in a very personal way, but you're going to be looking at it in a broader perspective. So Karen, if I can hand over to you at this point, and really looking forward to listening to you. Thank you.
Thank you, Sheila. I'll see if I can get my slides working. Hang on. Can you see this? Oh.
Yes, I can see your slide. Thank you.
Sorry, I apologise. I'm not very good at Zoom.
You're okay. You're okay. Take your time. And there's nobody giving marks out of 10 for how fast we put the slides up. So thank you.
Thank you very much. Hi, everyone. So thank you for giving me the opportunity to speak to you today. I'm Karen Hughes from Public Health Wales, and I'm basically a researcher. As Sheila has said, I look at this very probably from the opposite end of the scale from what we've heard from Richard, which was fantastic. Thank you so much, Richard. I'm looking at adverse childhood experiences from a population level. I'm going to talk about some of the impacts across the life course on health, a little bit on opportunities for prevention, and a lot of what I'm going to talk about is drawn from some of the studies that I've been involved in over the last probably decade now, predominantly in Wales and England, but also internationally as well. So, as we've heard, adverse childhood experiences, or ACEs, as they're commonly referred to, it's basically an umbrella term for a wide range of stressful and potentially traumatic experiences that can affect children whilst growing up, either directly, such as being a victim of child maltreatment or neglect, or affecting the environment in which they grow up, such as, of course, parental problem alcohol use, but also things like exposure to domestic violence and other experiences as well. And there's, over the last couple of decades, there's been a very rapidly growing body of research in this area, identifying these kind of experiences as being among the strongest predictors of poor health and well-being across the life course. So affecting everything from the very earliest stages of child development, increasing risks of health-harming behaviours, affecting opportunities for education and employment, and contributing to the development of physical and mental illness. We know that the more exposure children have to ACEs, the greater the vulnerability to poor health outcomes across life. But we also know, importantly, that ACEs are preventable and that their impacts can be avoided. And this is really important to remember as we talk through, because ACEs are common in populations. Lots of people experience one or more type of adverse childhood experiences, but many people are resilient to their impacts. So not everyone will go on to experience the health harms that I'm talking about. So I thought I'd start by talking a little bit about prevalence. As I say, lots of studies been done on ACEs to look at the extent of exposure in the population and relationships with health, often looking in adult populations and asking retrospectively about their exposure to adversities whilst growing up, so that this can be then linked back to their adult health. And most studies have focused on a range of ACEs that affect children predominantly within household settings. So various forms of child maltreatment, such as verbal, physical and sexual abuse, various difficulties within households, such as parental separation, domestic violence, and living with a parent or household member who has mental illness, who has problem alcohol use, who has problem illicit drug use, and who is incarcerated as well. But of course, children can be experiencing adversity in other settings as well, such as in schools, through bullying, through witnessing or being exposed to violent crime in the community, and through war and more societal level adversities as well. But most studies have focused on household ACEs. So this is the prevalence that we've seen in some of our studies in Wales. Looking within the general population, we see prevalence of individual ACEs ranging from 25% for parental separation, 20% experiencing verbal abuse as a child, to the less common ones of problematic illegal drug use, 6%, incarceration of a household member, 4%. But when you look at ACEs as a collective, you can see that about half of all adults in Wales report at least one ACE. So this isn't something that only affects a small proportion of society. This is a population issue. And we see about 12% of adults reporting having experienced 4 or more of these types of adversity while growing up. And this multiple exposure of 4 or more is often used as a point where the health risks associated with ACEs really start to increase. The data that we found in Wales is very similar to what we've seen in our studies in England. They've looked at this as a Scottish government have done a study nationally as well. They found similar in terms of 15% with 4 or more ACEs. Their figure for any ACE of 71% is largely due to the way that they categorised the ACE for verbal abuse. But similar studies across the world finding large proportions of the population having experienced one of these forms of ACEs whilst growing up, and a general portion, around about 1 in 10, have been exposed to 4 or more ACEs. So I had to look at what data was available for Ireland. I'm not sure if the data that Clíona presented was Irish data as well, but probably the best that I could find that was similar to ours was an online ACEs survey that was conducted in 2019, published by McCutcheon et al. And they did a nationally representative sample of 1,000 adults and found a prevalence of 65% reporting one of the 8 ACEs. So I think they looked at alcohol abuse, but not illicit drug use by family members, but all the others were the same as ours. They didn't report 4 or more, but they did say that the mean number people had experienced was 2. The prevalence of some of these ACEs is higher than we've seen, things like physical abuse and sexual abuse, some lower, but this is done slightly different to ours. It's online. Ours have generally been household surveys. And when we have done ACE surveys online, our prevalence has been a little bit higher as well. You also have studies at different ends of the age spectrum. So data from the Irish Longitudinal Study on Ageing has reported 34% with any ACE. Only 4 ACEs measured here. You can see the dominant one there is socioeconomic adversity, which hasn't been measured in most ACE studies, though it is in some. And also within child samples, so the Growing Up in Ireland study has looked at ACEs reported by caregivers to children under the age of 9. And you can see here 3% substance use, 14% parental separation, 12% parental conflict. So it's not directly comparable to the studies that we've done, but probably the prevalence that you see in Ireland is not too far off what we see in Wales. Importantly, as other people have already mentioned, most children who suffer one form of adversity within the household are also likely to be suffering other ACEs. So I used our data just to have a look at adults who had reported problem alcohol use as an ACE from all our surveys. So this is data for about 2,500 people in England and Wales who say they've suffered alcohol use as an ACE whilst growing up. And you can see that 88%, so the vast majority, are reporting at least one other ACE within there. 55%, so more than half, are in this high risk 4 or more ACEs category. The most common ACEs reported alongside problem alcohol use is verbal abuse, over half, parental separation, domestic violence, almost half, mental illness, physical abuse, 43%. So just to say, as already has been said, that often alcohol use is occurring within a complex kind of environment of lots of other adversities as well, which is really important when you're looking at prevention, because when you're looking to prevent one adversity, often you have to address the multiplicity of difficulties within households. So as I said, the more ACEs people suffer, the greater the risk of harm. This figure here is just to show the consistency of this relationship across a wide range of different health outcomes. So this is the proportion of adults from our England and Wales surveys that report different health outcomes based on the number of adversities they report in their childhood, ranging up from the grey bar, which is no ACEs, to the red bar, which is 4 or more ACEs. And you can see, for example, the proportions who say they've ever been diagnosed with mental illness increases from 23% with no ACEs up to 64% with 4 or more ACEs. For problem alcohol use, it increases from 2% of those with no ACEs up to 13% of those with 4 or more ACEs. And this is just to demonstrate how consistent the relationship is. But when you control for things like demographics and a level of deprivation and other confounders within people's lives, we find from our data that individuals with 4 or more ACEs compared to those with none are twice as likely to report being a high-risk drinker or a smoker, about 4 times more likely to report low mental well-being, current mental illness, 5 times more likely to report having had an unplanned teenage pregnancy and to abuse cannabis, 8 times more likely to have ever been incarcerated and to have been a victim of violence, and 10 times more likely to have been a perpetrator of violence and to report suicide attempts. So very strong associations across a wide range of health outcomes. And we looked at this globally a few years ago. We did a global review of ACE studies to see what the relationship was like across all the different studies that were being published. So we looked at 37 studies from 17 countries, and we found increased risks of harm across all the different outcomes that we looked at. A small increased risk in those with 4 ACEs compared with those with none, of things like physical inactivity, obesity, diabetes, around a 2 to 3 times increased risk of heavy alcohol use and smoking, and of a range of chronic diseases such as heart disease, cancer and respiratory disease, 3 to 4 times increased risk of risky sexual behaviour, mental ill health, 5 to 6 times increased risk of illicit drug use, problem alcohol use, sexually transmitted infections, and the largest risks for things like violence, victimisation, perpetration, problematic illegal drug use, and suicide attempt as well. So these things with the highest odds ratios are really the rarest events at a society level or population level, but they are health issues that are very, very strongly associated with adverse childhood experiences. So if you look in any youth justice population, any prison population, any substance abuse treatment population or mental health services, you will find extremely high levels of childhood adversity within the clients that are using those services. But also, these are things that can be ACEs for the next generation. So children who are exposed to ACEs become vulnerable to developing the kinds of health issues that then can make them vulnerable to exposing their own children to ACEs when they become parents. So Clíona's already talked about early life experience in the brain, but I thought from my perspective, give my perspective on this as well. So there are many reasons why ACEs lead to poorer health outcomes for people. And one of these is the impact of early life experience on the brain. Humans are very adaptive. And in the first few years of life, we go through a period of rapid brain development as we adapt to the environment in which we're going to be living. So the brain produces billions of cells and trillions of synapses that are the connections between cells. And then over childhood, these are then strengthened and pruned by the environment, really as the child adapts for optimal survival in the environment that it's going to be living in. And much of this is based on interaction with other humans. So when children grow up in safe and nurturing environments, these attachments or these connections can form things like attachment, trust, empathy, all these important features that are so critical in people being able to thrive in the social world that we live in. But when children grow up in violent or unpredictable environments, these connections don't get such opportunity to develop, and instead survival can be focused more on short-term survival. And one of the most important things is the impact of chronic stress from ACEs. So when anyone is faced with a threat, your body prepares to respond to that threat by increasing heart rate, blood pressure, muscle tension, releasing stress hormones, and entering what's known as the fight, flight, or freeze mode. Once that threat is removed, these all return down to at-resting levels. But this is a process really that's learnt during childhood. And when children are repeatedly exposed to threats, when they don't have caring adults around them to help them recover from that stress, the system can kind of develop into a heightened state of alert, as we've already heard about. It's basically a fixed allostatic load. So it overdevelops the life-preserving system, which means people are always prepared for further trauma, which is a very sensible adaptation strategy if you're going to be living in a dangerous world. But obviously it's at odds with other parts of society. It also places huge amounts of wear and tear on the body. And the overload of the stress hormones disrupts other parts of brain and physiological development, including cognitive development. So when children are focusing and dealing with a lot of stress, they're not having the opportunity to develop other areas of their brains, including things like learning, memory, and attention, which are so important for when they enter school. So research shows that when children who've suffered adversity in early life enter school, they can have lower levels of language literacy and math skills, lower levels of social skills. So they're already at a disadvantage compared to their peers. The impacts on relationship and anxiety and things can have difficulties with, have lower levels of peer and teacher relationships, lower levels of school connection, which can contribute to absenteeism. They can also have greater attention and behaviour problems. They can be more vulnerable to bullying, both as perpetrators and as victims. And they can have greater involvement in things like substance use and antisocial behaviour. And as we've heard, substance use can be also used as a coping mechanism against stress and trauma. There's also health impacts, so they can have disrupted sleep, somatic complaints and illnesses, which can contribute to absenteeism. And all this can contribute to lower grades, less school completion, lower levels of qualifications, which of course then moves into lower employment and earnings as well. So really important settings schools are for helping children kind of cope with stress that they might be experiencing at home. Along with the impacts on the brain and stress regulation, I say this can put huge wear and tear on the body, and we're seeing increasing evidence coming out about the relationship between ACEs and epigenetic changes, responses in the immune system and the metabolic systems, which means the biological changes embedded through ACEs impact on people's health risk behaviours such as alcohol use, but also there's physiological changes that can increase people's vulnerability to the development of chronic disease as well. So we see this in the ACE studies that we've done. This figure shows the proportion of individuals who are diagnosed with one of 5 major diseases through our studies: cancer, heart disease, respiratory disease, liver disease, and type 2 diabetes. The blue line is those with no ACEs, and the red line is those with 4 or more ACEs. We can see by the age of 59, 22% of people with no ACEs have been diagnosed with one of these 5 diseases, but this doubles to 44% in those with 4 or more ACEs. And what the data basically shows us is that these chronic diseases are developing on average 10 years earlier in people with 4 or more ACEs. So a huge burden on individuals' health from ACEs, but also, of course, on health services. So individuals with multiple ACEs are more likely to require frequent visits to GPs, more likely to attend emergency departments, more likely to stay overnight in hospital. So adding to the burden of care, but working from the opposite direction as well. We've also seen in recent studies that we've done that people who've suffered multiple adversities, they're less likely to think that professionals care about their health in the first place. They're more likely to report low trust in health services, and they're also less likely to engage with protective prevention things like COVID vaccination. So there's different forces working here that where people who have suffered ACEs are more likely to require health services, they're also less likely to trust in them. And this links into the importance of the provision of appropriate care and recognition of ACEs, such as Clíona was talking about trauma-informed services. But over the last few years, we've done a number of studies looking at the costs of ACEs and trying to get a financial figure on this, because that's always important in driving action. We looked first at a regional level at Europe and North America. I'm presenting data here for Europe, and this shows that across a wide range of, or 4 risk factors for health and 6 health conditions, the estimated costs that can be attributable to ACEs. So for alcohol, for example, we estimate that across Europe, 25% of all alcohol use is attributable to ACEs at a cost of $143 billion per year. This is US dollars. And those figures combined and removing duplication give us an overall cost of ACEs in Europe of 581 billion, which is 25 million disability adjusted life years lost per year. So an enormous cost. We then looked at this at an individual country level for all the countries that we had sufficient data to do so. And this figure here presents the equivalent that cost is in terms of each country's gross domestic product. And it tends to be on average around 3% per countries, ranging from, I think, just over 1% in Turkey up to 6% in Ukraine. And the figure here that we have for Ireland is 2%. It's slightly lower than what we had for the UK in 2.8%, but this was based on the best data that we had at the time, and the only ACE prevalence data we had for Ireland at the time was the study I presented earlier of adults aged 50 and over, which only measured 4 ACEs. So we did control for that and adjust for it in our analyses, but the prevalence that we assigned to Ireland estimated was slightly lower than that for the UK. So in fact, it's likely to be a little bit higher. But this is the data for Ireland that we calculated. So we looked at a couple of extra things in this study. We also looked at violence and stroke. And you can see that we estimated that 31% of all alcohol use in Ireland was attributable to ACEs, 31% of illicit drug use, 17% of smoking and 2% of obesity as our 4 risk factors. And then for health conditions, we estimated that 30% of anxiety, 25% of depression, 11% of cancer, 9% of cardiovascular disease, 11% of type 2 diabetes, 23% of respiratory disease, 17% of stroke, and 35% of violence could be attributable to adverse childhood experiences. And the combined cost of that was 100,000 disability adjusted life years per year, which equated to 7 billion euros per year. So an immense cost on society of adverse childhood experiences, but also showing what could be saved if you invested in prevention. So to summarise the impacts of ACEs across the life course, we see that exposure to ACEs can have neurological and physiological impacts on development, impacting on social, emotional and cognitive development, increasing the risk of adoption of health risk behaviours, the development of disease and disability and social problems, contributing ultimately to premature mortality. And there's biological mechanisms that push people up this pathway. There's intergenerational transmission, and this can lock families into cycles of ACEs, ill health and inequality, as people have already talked about. So breaking these cycles requires, 3 key kind of areas. Firstly is preventing ACEs from happening in the first place. We should be doing everything we can as a society to prevent children from being exposed to these kinds of adversities. We need to be building resilience in children so that when children are affected by ACEs, they have the personal skills, but also the social support and the networks around them to help them avoid the harmful impacts across the life course. And we also need to ensure that services and society recognises the impacts of ACEs, and that services are set up to be able to offer appropriate support to them. So I'm just going to mention a few little things around prevention, building or taking really from a piece of work that we've done, or a couple of pieces of work with the World Health Organization that was published last year. The first is a report, Tackling Adverse Childhood Experiences, State of the Art and Options for Action, which pulled together, all the information that we had about ACEs in terms of its prevalence, impact, risk factors, and also evidence of what worked in terms of prevention across different forms of ACEs, because often we talk about the evidence of what works to prevent child maltreatment, or what works to prevent intimate partner violence, or what works to prevent alcohol use. But when you look at these as a collective, there are some areas where you can see that these are, you're going to have best buys, because if you implement a strategy, it's going to affect more than one of these kind of ACEs. So we were trying to look at this as a collective. And some of the areas that came out as being important were around implementation of legislation and enforcement of legislation. The example that we give in this table is around banning violent punishment, but I think that's already been done in Ireland. But another core area, of course, is alcohol control legislation. Really, really important, not only in affecting alcohol use, but also evidence of its impacts on preventing child maltreatment, intimate partner violence as well. So really important. Parenting programs, of course, essential in terms of prevention, ensuring parents have the skills to parent effectively and develop those strong relationships with their children. School-based prevention programs and programs to build life skills in children, and also family-level multi-component, all have good evidence across a range of different adverse childhood experiences. Resilience as well has been talked about, and this is really important. And I think when we're talking about household multiple exposure of ACEs in the household, what we're largely talking about also is the lack of that nurturing care that's really important for healthy child development. And if, in terms of resilience, obviously you want that first and foremost to be built within the family, but where it's not, it should be provided elsewhere. Having trusted adult support is one of the strongest factors in resilience for children, and it's critical that children have that from somewhere in their lives. Other areas around, supportive communities, strong cultures, and systems that are capable of being responsive to problems as well. So the second report in this series was a practical handbook on ACEs that we published to try and help countries, this is done at a European level, kind of think about where they might start if they were going to be addressing ACEs. And it follows a very public health approach, so assessing the current situation by collecting data on it, using this to raise awareness, developing partnership working, selecting interventions based on evidence, providing training and support, evaluating action, and then scaling up, embedding and sustaining effective action. So I thought I'd finish by just saying a little bit about how we've done this in Wales. We've been working on ACEs in Wales for almost a decade now, and we started the work by doing the first national ACE study for Wales that we did in 2015 that took a measure at a general population level of what the prevalence of ACEs was in adults, what relationship this had with health harming behaviours, with chronic health conditions, with mental health, and what it might look like as well if we prevented ACEs in future generations in terms of reductions in problems like violence and cannabis use and teenage pregnancy. So trying to touch on multi-agency agendas with that. We use that to advocate for change, and our government was very forward-looking, and they adopted this, and they included ACEs in the national strategy in 2017. They made a commitment to create ACE-aware public services, which take a more preventive approach to avoid ACEs and improve the resilience of children and young people. So this was really integral to us in developing a kind of societal approach to preventing ACEs as well. They also established an ACE hub, which was a coordinating centre for sharing knowledge, evidence and expertise, which was situated within Public Health Wales, but with multi-agency ownership, and has been really important in pushing this work forward. We did a lot of partnership working, and often with issues like this, the police are the first people to respond to it. The police are very action orientated, and they could see very clearly it resonated with them because they deal with vulnerability on a daily basis. Often they go in and see the same families over and over again. The children within those families don't meet the thresholds for entering social services, and they can see them repeatedly until they do meet this threshold, or they end up in youth justice themselves. So the police really saw their role in doing that, and we did a lot of training and work with the police to try and change their perceptions of these families, make them understand trauma and vulnerability, and try and establish systems to help those people who weren't meeting the thresholds, those children. We looked at things in lots of other areas as well, things like routine inquiry and health visitor programmes in general practices, work in prisons, work in housing sectors, really just trying to see how we could look at improving our existing services to make them more ACE aware and train people up on this and be better at helping people that were coming through our services. We did training across a wide range of agencies, like all primary schools in Wales, and I think all secondary schools as well received ACE training for teachers, and this ESTIN is our the governing body for schools in Wales that produced resources on adverse childhood experiences as well. We evaluated everything as you are often required to do, and to inform our work, and we've kind of continued that throughout over the last almost a decade now, as I say. But where we are at the moment is we've moved into trauma-informed kind of framework and language within our work. And we published a couple of years ago Trauma-Informed Wales, a societal approach to understanding, preventing and supporting the impacts of trauma and adversity, which is trying to make Wales, the whole of Wales, trauma-informed, starting with the universal awareness raising across society so everyone understands trauma and their role in supporting friends, neighbours, colleagues, looking at trauma skilled level where it's most organisations and services who provide support to people who may or may not, but just making sure they're aware and skilled to understand trauma. Trauma-enhanced services for frontline services who are dealing with people who have suffered trauma, and specialist interventions, both for those who need additional support and for specialists to go in and help organisations become more trauma-informed themselves. So that's where we are. You know, it's been a really interesting journey. It's been very well received in Wales, and you know, there's loads of resources available on the websites if anyone's interested in them. But just to summarise, so ACEs are among the strongest predictors of poor outcomes across the life course, and they really need to be considered across the life course. So if you prevent ACEs, you'll benefit health, but also education, employment, social welfare, crime. It's a real multi-agency issue. Building resilience can help buffer children who suffer ACEs from their harmful effects and benefit health across all children. But importantly, resilience is never going to completely remove the impacts of ACEs, so prevention is always going to be the kind of the top priority. And services that understand ACEs can deliver more effective support to those affected by them. So this is our being trauma-informed. Health, social, education, criminal justice sectors all benefit from starting on the right life trajectory, and if you break it in one cycle, you can have long-lasting intergenerational benefits also. So thank you very much.
Well, Karen, thank you so much for that. That was a whirlwind through like a massive amount of data. An awful lot of the data, I will just say to you that we do use that, and it really does inform our advocacy work. So we are so grateful to the people who carry out this sort of research, and it really is helpful. Certainly one thing that just jumped out at me there, the cost in Ireland of ACEs, that you have an estimate there at 8 billion. And as you say, it's probably an underestimate, you know, but it's a huge cost. One thing that I just wanted to ask you, and this is really my advocacy hat on, when I look at Wales, and we see also Scotland is doing work in this area as well, but Wales has, you know, really embraced, you know, this particular issue, and, you know, really tried to develop, you know, a framework and resources around it. Why and how do you think did that come about in Wales? Because I think we're moving in Ireland towards that. There's individuals who are doing good stuff, but I wouldn't say that across the government we have the same scope of what we're seeing in Wales. So just wondering, any insight into how did it come about?
I think, I mean, when we first did our surveys in Wales, there wasn't very much data on ACEs. It was not really heard of. So we did probably the first national study in the UK on adverse childhood experiences, and the data that came out of it was very novel. It was very powerful, and also it came from the National Public Health Agency. So it was seen as a very national picture. And with that, we did a lot of advocacy work. We also benefit from, we have a fantastic piece of legislation in Wales called the Wellbeing of Future Generations Act. I don't know if you've heard of that or have anything similar in Ireland, but this mandates all services in Wales to think about the impact of their work on future generations. And I think this came out and it resonated very much with that line of work, and people could clearly see the impact. I think making often prior to the ACE work, I mean, people have their thoughts on it, whether it's good or bad at how we look at these. But what I think the focus on ACEs does is it brings people together with a shared agenda. It shows the impact of childhood adversity across multi-agency agendas. So you can see its impact on education, you can see its impact on policing, you can see its impact on everything. And it tries to bring together the benefits of working together to address it. So if you can get the police can see the benefits of them investing in early life interventions rather than focusing and waiting for crime. I think it just enables a much more societal approach. So I think there's a lot of it in terms of how I think the data is essential, and I think that data has to be localized or nationalized to the population. And if you can set that picture out, what the cost is to your country, what the impact is on your population, and importantly, what people can save by preventing ACEs, then you can get people working together to address a common agenda. And I think that's what happened in Wales.
And that's very, very interesting. And actually, I'm particularly interested in just what you're saying about the police side of things. We have a speaker, our third event, just for people who are here, our third event this week on Friday will feature a researcher in Belfast, Dr. Anne-Marie Miller, who's looking specific at interventions and work with police and trauma-informed elements on that. Marion, I'll just hand over to you there.
Yes.
Yeah.
Thank you very much, Karen, for a fascinating presentation. I first heard about the ACEs study in a presentation by Professor Mark Bellis in Trinity some years ago, and I really completely changed my whole experience of working in addiction in terms of understanding, you know, the evidence then for ACEs. I in particular, I remember this video that's on YouTube of this little character who goes from childhood to adulthood, and I'm sure you're familiar with that piece. It is a fantastic. So I can see how you might convince your audiences with that video alone, because it just shows the, you know, the damage and danger of ACEs and the impact. So was it widely available at the time?
Yeah, we did. We used that video in a lot of training sessions and presentations, and it was very well used. We did in the training that we did for the different services as well. We used that clips from that video as well. So yeah, I think all that advocacy work that went on. I'd actually forgotten about that video. It was a long time.
I use it all the time. I use it all the time.
That's nice to know. Yeah, it was translated into a lot of languages. So yeah, we've done things like that are really important, and we've done since then not such a focused one, but we've done other public-facing advocacy work as well, which is we had a campaign like Time to Be Kind, which is just about putting out to the public to recognise, you know, the impacts of trauma that they might see in their neighbours or their friends, and just being kind to each other. So we've used that video format a lot with people as well.
Great, great. Because we have a trauma-informed city in Cork. They've been working on that for many, many years, and I know in different other areas of Ireland as well. But in particular, there's a strong community action on trauma-informed and trauma-aware. So thank you. And I was also wondering about, you know, commercial determinants of ACEs, and if there's any work done on that in relation to, say, the drinks industry, just what Richard was talking about this morning and all of that. Is there anything, any influences there from government on that?
We recently did wrote a paper on commercial determinants of violence, which links in to that. I mean, commercial determinants is something that's very much increasing across the public health agenda. It's becoming, you know, the next big thing to us, and there's so much that we need to be doing to tackle this. It's obviously alcohol is a major one. And one of the key ones, but also things like technologies and how they're being used to exploit children and to kind of push children down pathways in terms of you know, sharing hatred and messages. There's so much there that needs to be done. It's currently a neglected area, but it's one that I'm extremely interested in. Yes.
Great, thank you, Karen.
Thank you. And actually, I see a question in the chat, if we could put a link to the YouTube video. But I think what we'll do is we'll track it down, and I'll email it out to people afterwards, just because it might just be a wee bit hard just to find it straight away on that. I would just wonder, Owen, was there anything else?
Yeah, there's just one other question. And look, a lot of people are very, very thankful, Karen, for your presentation. And have commended your work and have pointed to the fact that they will be referencing your work further in their own professional arena. But I have just Stephen points out that sometimes we can get fixated on outcomes, i.e. alcohol harm, But he says it's really important to look at the causes of alcohol use in terms of what drives humans to such destructive behavior sometimes. He points out that, you know, that some people can have a physical allergy to alcohol, and the reaction sometimes is a physical craving which compels them to consume more, and you know whether that is true in your experience, Karen, or if you've come across that, or what can be done to help people where we focus in on the causes of their alcohol use to ensure that we cut off any development of ACEs kind of at the pass, and we break that domino effect in the first instance, is how we help people in that regard.
Yeah, it is. I mean, I look at these things at a population level. So often, what I'm focused on is what we can do at a much higher level than the individual. But everybody will have their own drivers for different reasons why they use alcohol. But a lot of them are about very strongly linked to how people's brains work. So I guess it's understanding. Finding out what are those drivers. I'm sure there's a lot of research out there on the individual drivers of alcohol use and why different people might have it. So it's, I guess, making sure that the action for the individual is targeted appropriately. And part of that is understanding the history that people have, because sometimes people might present at services with one issue, but unless you understand the history of that and what might be driving the thoughts and feelings that people are having, you might not get the treatment right for it.
Very, very good. Karen, there was an awful lot, within that, and very, very much appreciated, say, taking things from multiple different areas. Again, one of the things that we have been looking at recently is trauma-informed education, and we have worked with Maynooth University and putting together some resources and materials there. So if people are interested, that's just another place to find some links. On our own website, you'll see lots of that kind of information. We do have a toolkit of resources which again links to puts in a lot of the evidence and the types of supports that maybe could be of use. I think we're kind of coming quite near the end of our talk this morning, our set of talks this morning. A couple of things that I'd really like to do myself is firstly to thank all our speakers, and I'm aware that a number of people were actually juggling a lot of difficult situations this morning, so I really, really appreciate the help that all three speakers gave to us on that. I particularly want to thank our own team here. Owen's been keeping such a close eye on the questions. Thank you. Connor's been going hell for leather on the social media. Marion, thank you so much. Marion, I didn't introduce properly, and I do apologize actually at the start, but Marion is actually a co-founder of Silent Voices, and in fact actually she was also the first director of Alcohol Action Ireland. But Silent Voices was started back in 2019, and since then, in the course of now nearly 6 years, we have tried to point a spotlight on different aspects of this particular problem, parental problem, alcohol use, and its impact on children. So whether we're talking about that in the healthcare setting, whether we're talking about it from an education, whether we're talking about it in a cost to society, we are constantly trying to seek out the information and the evidence and to bring that to government in various ways. We have an election coming up. I'll probably appeal to everybody who's on the call here now. When politicians come to your door, I think it's worthwhile, raising this and saying, what are you going to do to try and address these issues? One of the things that we would really like to see is an office, a dedicated office for alcohol centred in the Department of Health that would coordinate policy across the multiple different departments which are impacted by alcohol in various ways. So you might like to consider that as something perhaps to say if somebody knocks on your door. At this stage, I think we're just going to pull ourselves together and say goodbye. I want to say to you, though, we have 2 more events this week. We have an in-person event in the Mansion House, which is on Wednesday at 7 o'clock. And there's still literally a few tickets, but I think it's down to a handful of tickets that are still left for that. And then our final event is on Friday, and it is a webinar. And again, you can have a look for that and book for that online. It is at 11 o'clock. And again, if you just take a look at our website, you can see the booking details there. We also have a podcast which we launched yesterday featuring Marion, indeed, with another of our speakers, Aisling Cregan, and Aisling will be taking part in the event on Wednesday. So there's loads going on in this sphere. I hope there's something that's of interest to all of you who have been tuned in, and I thank you so much for all of your contributions. Thank you.